Medical news from Medrxiv. Comparison of influenza vaccine effectiveness estimates using test-negative prospective enrollment and electronic health record data, United States, 2024 to 2025. Influenza vaccination reduced the odds of laboratory-confirmed infection by roughly one-half during the 2024-2025 season, and the magnitude of protection was virtually identical whether the estimate came from a classic test-negative design with prospective patient enrollment or from a large electronic health record (EHR) database. Demonstrating concordance between these two methodological approaches matters because public health agencies rely on timely vaccine effectiveness (VE) data to guide policy, and EHR-derived estimates could potentially be generated faster and at lower cost than traditional field studies. Seasonal influenza remains a leading cause of morbidity and mortality worldwide, accounting for hundreds of thousands of hospitalizations in the United States each year. Although annual vaccination is the cornerstone of prevention, VE can vary substantially from one season to the next, driven by antigenic drift, vaccine composition, and host factors. Historically, the gold standard for measuring VE has been the test-negative case control design, in which patients with acute respiratory illness are prospectively recruited, tested for influenza, and compared by vaccination status. Parallel efforts have explored the use of routine clinical data, diagnostic codes, laboratory results, and immunization records to derive VE estimates, but the degree to which these real-world calculations mirror prospectively collected data has not been rigorously quantified. In this investigation, the U.S. Influenza Vaccine Effectiveness Network enrolled outpatients at 7 geographically diverse sites who met a standardized clinical screening algorithm for acute respiratory illness. Nasopharyngeal swabs were obtained and tested by RT-PCR to confirm influenza infection. Simultaneously, each site extracted an EHR cohort comprising all outpatient encounters coded for medically attended acute respiratory illness, MARI, during the same period, linking each visit to any documented influenza test result and vaccination record. Both datasets were analyzed with multivariable logistic regression that adjusted for age, site, and month of illness, producing VE as 100 times 1 adjusted odds ratio. The prospective arm included 6,793 participants, of whom 2,016, 30%, tested positive for influenza. The EHR arm captured 282,444 MARI visits, with 75,885, 24%, laboratory-confirmed cases. The adjusted VE derived from the prospectively enrolled cohort was 46%, 95% CI 38 to 53%, p less than 0.001, indicating that vaccinated individuals had roughly half the odds of infection compared with unvaccinated peers. The EHR-based analysis yielded a VE of 44%, 95% CI 37 to 50%, p less than 0.001, a difference of only 2 percentage points that fell well within overlapping confidence intervals. Subgroup examinations showed comparable protection across age strata, with adults aged 1849 experiencing VE of 48%, prospective, versus 46% EHR, and those greater than or equal to 65 years showing slightly lower but still significant VE of 39% versus 37%, respectively. No statistically meaningful interaction was observed between vaccination status and underlying comorbidities, suggesting that the vaccine performed similarly in patients with chronic lung disease, cardiovascular disease, or diabetes. These findings reinforce the reliability of EHR-derived VE estimates, implying that health system data can serve as a rapid, scalable supplement, or even an alternative, to traditional field studies for monitoring seasonal influenza vaccine performance. For clinicians and public health officials, the near-identical VE figures support the continued recommendation of annual influenza vaccination, especially as the season progresses and vaccine uptake may wane. Moreover, the ability to generate timely VE metrics from existing clinical records could accelerate decision-making around vaccine strain updates, targeted outreach, and resource allocation during peak influenza activity. Nevertheless, the study carries inherent limitations. The prospective arm, while rigorously standardized, enrolled a relatively small sample compared with the massive EHR cohort, potentially limiting power for detecting modest effect modifications. The EHR approach depends on accurate coding and complete capture of laboratory testing. Misclassification of illness or vaccination status could bias VE estimates toward the null. Additionally, the analysis excluded patients who sought care outside the participating health systems, which may affect generalizability to broader populations. Despite these caveats, the close alignment of VE estimates across methodologies provides compelling evidence that routine electronic health data can reliably reflect vaccine impact, offering a pragmatic tool for ongoing surveillance in the ever-changing landscape of influenza epidemiology. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.